After yesterday's session where I was telling you guys to go back to the step 1 book over here and add in the treatments, I did add some of them in. So I do recommend really doing it. It's actually stuff you can find throughout the CK book. Some of it was discussed in the same area we were in yesterday. And what it really helps with, like putting in the fact that, this is what you use for candida over here, but you use only this when it's candida esophagitis, and then for histo, pneumocystis, and then of course CMV, crypto, and mycobacterium, as well as toxo. By putting these in, not only did I realize that, of course, it was easier to memorize these treatments over here in this manner, but also the fact that these are actually the ones that are the most high yield questions for patients with HIV. Like, it's extremely rare for you to get an HIV patient question where the question is actually about, maybe like Epstein-Barr virus or even JC virus. This one is actually really rare, really rare. JC and BK both are very specific questions. For example, JC virus is actually a question you'll be differentiating between JC versus whether it's toxo or not. And the only way to really do it is the fact that JC virus causes non-enhancing areas of demyelination on MRI, whereas toxo causes ring-enhancing lesions, right? So there's actually a glowing halo type of ring that occurs in the brain. That's what you call enhancing. Whereas here they're just little bullet shots, right? And it's very easy to catch it. Progressive multifocal leukoencephalopathy, PML, is what you just call it. And it's a very easy thing to look up and not that complex at all. But the ones that are extremely high yield are the ones that you put out these explanations for. And then, of course, if you're ever doing practice questions and you see something like on your practice questions, you might easily see Bartonella. And so with Bartonella, you always want to remember that with healthy immunocompetent patients, it doesn't really cause much. It doesn't do too much to them. But, you might get a little bit of like lymphadenopathy and that's it, and they recover. But with immunocompromised patients, so that means anyone, not just HIV patients, but even patients who have very weak immune systems for any other reason. Maybe they're taking immunosuppressive therapy because they just had a transplant, or maybe they have really bad leukemia, and that's also where you lose some white blood cells. So those patients can get bacillary angiomatosis where you would do the biopsy and you would see neutrophils, because that's what you need to beat Bartonella. You would see neutrophilic inflammation rather than lymphocytic inflammation, right? And that's kind of what helps you figure that out. Alright, so other than that, if we continue on, now we're up to the part where we talk about the STDs. Which, as far as CK is concerned, you have to remember that a lot of these topics can also present in conjunction with patients who are immunocompromised. So you have to be careful with that. Now, STDs affect everyone, whether you're immunocompromised or not. But patients that are immunocompromised will have a slightly different response to STDs as opposed to immunocompetent patients. So first thing they talk about here, chlamydia, then they go on with gonorrhea. Those two are the big guys that you really have to know extremely well. There's a whole topic of syphilis that we discussed, all the same things from step 1. Genital lesions, and then of course you're going to have to know the difference between painful versus painless. And of course the painful guys are Haemophilus ducrei and herpes. Those two guys cause painful lesions. Then we have a bunch of practice questions, and we'll be done with that. So let's take a good look at what's happening with all of that, and we'll also go back to our step 1 book as necessary. So first guy, chlamydia, the most common bacterial STD in the United States, caused by C. trachomatis, which can infect the genital tract, urethra, anus, and eye. Risk factors include unprotected sexual intercourse and new or multiple partners. Often coexists with or mimics Neisseria gonorrhea infection, known as non-gonococcal urethritis, when gonorrhea is actually absent, right? Lymphogranuloma venereum, LGV, serors of the C. trachomatis cause lymphogranuloma venereum, an emerging cause of proctocolitis. Now that is becoming a little more popular lately, so you definitely want to make sure you look this up a little more. We will talk about it as well. Let me also find actually right where chlamydia is discussed over here. Right here. Right. So there's this group of topics right here, the sketchy microimage, and then they break down the different serotypes, right? So the lymphogranuloma serotypes are the ones types that starts with an L, L1, L2, L3. Lymphogranuloma venereum are small, painless ulcers on the genitals that lead to swollen, painful inguinal lymph nodes, which can actually ulcerate, and that's actually called a bubo. So we also see buboes and other things as well. Like the other common thing that causes buboes was one of the things related to prairie rats. Forget what it was. Let me see. It was one of your zoonotic bacteria. Right here. None of these guys. What was it called? The guy that causes buboes. Let's find it. Because they're both, well, the other guy that I'm talking about that causes buboes is not that high yield. Oh, right here, this guy. So you see this character standing in the back right here. This is Yersinia pestis. Slightly high yield, not exactly very high yield, but it can be. So the guy standing back here, he has these red things in his armpits. That's lymphadenopathy. That's very painful, right? So that's what they're referring to as the buboes for patients. So chlamydia also causes buboes, although the term bubo is more commonly used with Yersinia. You talk about buboes more commonly when you discuss Yersinia topics. So chlamydia cannot make their own ATP. They are obligate intracellular organisms that cause mucosal infections. They have two forms, the elementary body and then the reticulate body. Right? So the elementary is infectious, reticulus replicates. These were typical, very unnecessary topics that you had to know for step 1. Not necessarily something you'll need to know for CK, but it's still nice to have that on the back of your mind. Chlamydia trachomatis, which also has the term trachoma in it, which is the blindness. Trachomatis causes neonatal and follicular adult conjunctivitis. Right, so it's really bad. And that's what they're showing you here. So this is actually the eyelid being lifted over. Non-gonococcal urethritis, so urethritis with no gonorrhea. Pelvic inflammatory disease, which is a combined problem with both chlamydia and gonorrhea. And reactive arthritis. So reactive arthritis has always been depicted in sketchy with some guy who's laughing at something and smacking his knee. So that's kind of what's happening here. He's laughing at one of the 3 monkeys, which are also depicting the major features of what chlamydia causes. Chlamydophila pneumoniae and Chlamydophila psittaci are atypical pneumonia. Right? So both of them cause atypical pneumonia transmitted by aerosol. Psittaci specifically is usually related to parrots, which is why you have this beautiful parrot there. And treatment is with azithromycin, which is just a one-time treatment, and that's it. You could also use doxycycline, but you have to use doxycycline more than just one pill. You could also, you need to also add ceftriaxone just in case they got concomitant gonorrhea infection as well, because oftentimes if you got chlamydia, you probably got gonorrhea too, and vice versa. They both go together for the most part. Right? And then here they break down the serotypes for use. So types A, B, and C are literally you just memorize Africa, blindness, and chronic. Right? So they cause chronic infection, cause blindness due to follicular conjunctivitis in Africa. So if you get a patient who came from any part of Africa and now they're suddenly getting blind, then you can figure out that it must be related to chlamydia types A, B, or C. Types D through K are what we usually get tested on. These are the ones that cause urethritis and pelvic inflammatory disease, which can lead to ectopic pregnancies, neonatal pneumonia with a staccato cough. So staccato is a music thing. So staccato cough is a very almost like a cough with a beat to it, basically. With eosinophilia and neonatal conjunctivitis, which is very delayed, 1 to 2 weeks after birth. Okay, so neonatal disease can be acquired during passage through the infected birth canal. So if the mom has chlamydia while she's about to deliver, then of course the baby can get it, and it causes a very delayed conjunctivitis. So you need to keep that in mind because that's going to be in comparison to the other big guy, gonorrhea. Right, so gonorrhea causes immediate blindness, and you don't need to know the full sketchy microimage, but what is happening here, you make it bigger. What is happening here is this woman is sitting in a seat that looks like a white blood cell, right? Because gonorrhea are inside white blood cells. And what's special about what she's doing is that she's covering her baby's eyes immediately because the statue just fell on this guy and the guy died. right? So she's basically stopping the baby from seeing that, and she's doing it very quickly. So that's supposed to remind you that it causes blindness in neonates almost immediately after they're born. And it is a medical emergency, as we've seen before, and we'll see more of it as we look at practice questions. So that's something to keep in mind. That's a tiny but critical fact that'll help you differentiate between whether someone has chlamydia or gonorrhea, conjunctivitis. Right? What's the root cause? And then, of course, the statue falling and its knee breaking and killing this guy are all signs of migratory migratory arthritis. Right? Migratory arthritis, where you might have pain in one knee and then the next day you have pain in your right shoulder, stuff like that. So that's kind of what they wanted to depict here. You see neonatal conjunctivitis 2 to 5 days after birth. Right? So this is really important. And then they used to talk about the thickness. Oh, right here. So I wrote it. They don't talk about it much. But gonorrhea has thicker purulent discharge than chlamydia. The way to remember that is you see this chandelier at the top. The way the chandelier is designed is supposed to represent the urethra and the ovaries. The candles are the ovaries. Right? So that's what they're showing you here. And it's all on fire because of pelvic inflammatory disease. The candle wax that's melting and falling is very thick candle wax. That's supposed to remind you that not only does the conjunctivitis occur really rapidly, but it's also going to be extremely thick. Right? So this is actually a really big emergency. Treatment is just ceftriaxone, and then adding azithromycin or doxycycline is just for chlamydia, but treating gonorrhea is with ceftriaxone. All right. And then erythromycin eye ointment is what you would use for the neonatal blindness part, not ceftriaxone. So there's multiple forms of treatment for everything. There's multiple combinations you might see in answer choices. Like you might see an answer choice that says give ceftriaxone and azithromycin. That's valid. Give ceftriaxone and doxycycline. That's also valid. If you have both answer choices, you pick the azithro because azithromycin is just a one-tablet treatment. It's an easier treatment. It's a better way to go with it. You can have both answer choices. You could have ceftriaxone plus azithro and another answer choice of ceftriaxone plus doxy. Right, so what you pick will really depend on a couple of things. One, of course, generally speaking, if there are no contraindications, ceftriaxone plus azithro is a better answer choice. But if the patient has any allergies or any condition where azithro wouldn't be preferred or doxy wouldn't be preferred, then you can alter your answer choices accordingly to that. Okay. So moving on, infection is often asymptomatic in men and may present with urethritis, mucopurulent cervicitis, or pelvic inflammatory disease in women. Exam may reveal cervical adnexal tenderness in women or penile discharge and testicular tenderness in men. The testicular tenderness is something that STEP uses to confuse people. Right? Usually testicular tenderness could be related to the blood vessels being all twisted and stuff. With the condition of testicular torsion, but it's not torsion, so be very careful with that. Differential diagnosis includes gonorrhea, endometriosis, pelvic inflammatory disease, orchitis, vaginitis, and even urinary tract infections. The lymphogranuloma venereum aspect presents in its primary form as a painless, transient papule or shallow ulcer. Then it progresses to a painful swelling of the inguinal nodes, and in its tertiary form, it can present as an anogenital syndrome where you have anal pruritus with discharge, rectal strictures, and a rectovaginal fistula and elephantiasis. This topic of lymphogranuloma venereum is one that very few medical students actually have down pretty well. And so it's not really talked about that much in Step 1. I don't know if it's more common on UWorld Step 1 now, but before UWorld, I don't even think had a single lymphogranuloma question. So it wasn't something students were really that aware of. Now you're seeing more about it, and it's becoming, as they're saying, it's an emerging problem, right? They wrote that in, right here. It's an emerging cause of proctocolitis. So you want to make sure you know this pretty well. Now, generally speaking, we only refer to two things that cause painful lesions, right? The two things were your Haemophilus ducreyi and herpes. This doesn't cause painful lesions, so be very careful with that. It just causes painful swelling of the nose, or painful lymphadenopathy, which was the buboes we were talking about. But the ulcer and the papule, those things, they're not painful. So very important to keep that in mind. Only painful lymphadenopathy, not a painful ulcer. And then if your patient is presenting with any of these anogenital syndrome symptoms, right, where they have anal pruritus, rectal and rectovaginal fistula, and all these things, then you really want to think of lymphogranuloma venereum, chlamydia with one of those serotypes. All right. Diagnosis is usually clinical. Culture is the gold standard. You have to do culture to actually see it. Urine tests with NAAT, nucleic acid amplification tests, are a rapid means of detection where DNA probes and immunofluorescence take 48 to 72 hours. Right? So your DNA probes and immunofluorescence are not going to be a good enough answer choice to pick because it's just going to take too long. And one of the special things to keep in mind is you do not wait for results. Right? If you have suspicion that the patient has chlamydia or gonorrhea, you start them on the set of antibiotics, both the ceftriaxone for gonorrhea and the azithromycin for chlamydia, right away, because there's no harm in taking those medications, right? If they have it, then they'll be okay, they'll survive, and you want to start treatment before pelvic inflammatory disease develops, because if it's a female, then they're at the risk of having damaged fallopian tubes, which is going to lead to ectopic pregnancies down the road, so you don't want to risk any of that. So urine test with NAAT you could do. It is a rapid detection test, but not everywhere do you have this available. This is usually available in most gynecology clinics, but not in most family medicine and internal medicine clinics. So diagnosis would usually require to do a DNA probe or really just take a culture and send it in. But even sending in culture is going to take more than 24 hours. You're not going to get someone that's going to tell you what they see in the culture right away. Treatment for 7 days of doxycycline or just one tablet of azithromycin. Use azithromycin or amoxicillin in pregnant patients. So you see how you could have both answer choices. Right? If your patient is pregnant though, then azithromycin will be the answer. Of course, doxycycline is slightly teratogenic, and we all remember how doxycycline, the tetracyclines, can cause yellowing of the teeth and they can affect the bones of the baby. So you don't want to give doxycycline to a pregnant woman. Right. Treat sexual partners and maintain a low threshold to treat for Neisseria gonorrhea, which means you treat for Neisseria as well. LGV serovirus require prolonged therapy for 21 days. Right? So if they have the lymphogranuloma aspect, you have to give the medications for even longer. Now there are some complications that can arise. Chronic infection and pelvic pain. You could get Reiter syndrome, which is one of the reactive arthritis things. Right? So you have your Reiter syndrome is just urethritis, conjunctivitis, and arthritis, but this is the reactive arthritis, which is an autoimmune type of arthritis due to other things that occurred, like this infection. You could get the Fitzhugh-Curtis syndrome, which is a perihepatic inflammation and fibrosis, and you get those, what they refer to always as guitar string lesions like this. So what you're seeing here is the liver and these connections of the liver with everything else around it. Right, so these adhesions from the peritoneum to the surface of the liver. And this can get worse, and then it can fibrose, and it's just problematic. So you don't want that to develop. Ectopic pregnancy or infertility can result from pelvic inflammatory disease in women, while men can get epididymitis, which is also really problematic, right? Because that can also affect their ability to be fertile. If their epididymis doesn't work too well, then things are going to be pretty bad for them. Gonorrhea here, gram-negative intracellular diplococcus that can infect almost any site in the female reproductive tract. Infection in men tends to be limited to urethra. Presents with a greenish-yellow discharge, pelvic or adnexal pain, and swollen Bartholin glands. Men experience a purulent urethral discharge, dysuria, and erythema of the urethral meatus. The differential diagnosis includes chlamydia, endometriosis, pharyngitis, even this, because of course it's involving a lot of things, pelvic inflammatory disease, vaginitis, salpingitis, a bunch of other things. Of course, all of these things are things you should know how to differentiate though, like a tubal ovarian abscess. This will usually only occur on one side, right? Whereas gonorrhea is affecting the whole system, so it's not going to be unilateral. And an abscess will also always, any abscess you have anywhere in your body, unless it's inside an organ system, like inside your lungs or something, if you have an abscess outside of an organ, it will limit mobility because it's going to be taking up space, and you won't be able to move your body the same way when you would be able to move it when there was no abscess there. So usually you'll see like inability to move one of the legs or something like that, and that's what you utilize to understand that it's an abscess. The constantly changing weather of New York is really, really something. Like, I'm not sick or anything, but ever since yesterday I've been noticing I've constantly had to clean my nose and stuff because it's like really warm today. Whereas just last week it was pretty cold. Alright, so gram staining culture is the gold standard here as well. So you usually send in culture for both things because you won't know which one the person has. NAAT can be sent on penile or vaginal tissue or from the urine, which you also do. You collect urine for both case scenarios, chlamydia and gonorrhea. So generally speaking, you'll do both things. You'll do the NAAT and you'll also send culture, and you'll wait, but you start treatment the same day they came. You don't wait for results. Okay, that's something that I really feel like they should have written here, right, but they didn't. Yeah, they really should have written it. Start treatment even though you don't have the results yet, right? So that's something you have to keep in mind. I'm not sure why they didn't write it. That's something that's definitely a very big CK thing to teach, because you'll have other answer choices like wait for results or no treatment right now, etc. No, you start treatment right away. If someone comes in, you look at them, you examine them, you figure out it looks like it might be chlamydia or gonorrhea, you start the treatment. There's no harm in that treatment, and on top of that, if you don't treat it, things can get really bad. Ceftriaxone IM and azithromycin PO, regardless of whether chlamydia is present. See, so with this gonorrhea patient, you're treating for chlamydia regardless of whether the results are there. Same goes the other way too, and you always start treatment for both, regardless of whether or not you have proof for either. Condoms are effective prophylaxis. Treat the sexual partner or partners if possible. Fluoroquinolones should not be used because of emerging resistance. Disseminated disease requires IV ceftriaxone for at least 24 hours. Right, so that's really it. Treat gonorrhea with 2 agents because of higher prevalence of resistance. And so treatment of gonorrhea, ceftriaxone and azithromycin is what they're saying to use now. Right, just give both things. But the azithromycin is really for the chlamydia, so I'm not sure what they mean by treat gonorrhea with 2 agents. There's only ceftriaxone. Let me see, did they mention anything else? No, they didn't mention anything else. I haven't seen anything else either, but there is a practice question coming up where, let me just make sure it's here. It's not right here. There's a practice question somewhere in this segment for chlamydia and gonorrhea. I'm surprised I didn't put it right there though, where they gave a really nice table with the breakdown of all the treatments for both of them. But either way, when you see it, you'll see it, I guess. But yeah, I don't know why they're, we all know first aid CK is very incomplete. They have things they write and then they have things they forget. But generally speaking, I haven't seen anything else. Even here, we can see it, right? It's just ceftriaxone, and that's it. So I don't know why they're saying treat gonorrhea with 2 agents, because there's only really one thing. We'll see. If we see it in practice questions anywhere, we'll get it down. This kind of stuff, if you ever get a question with someone presenting with this, and they'll tell you it's painful, these are easily confusable with the oscillor nodes that you're also supposed to get in infective endocarditis, so be very careful with that. But these are actually hemorrhagic painful pustules that are seen on erythematous vases in disseminated gonococcal infection. So of course, STEP always tries to be really complex with starting off with things that are far-fetched and then trying to get you to connect it to something that's very obvious. So don't get too confused if you get stuff like this. Just focus on what's really happening and the age of the patient, and if you think they have if you think they have infective endocarditis, then you need to consider, do they have any of the matching risk factors to get endocarditis? If they don't have any of those risk factors and they don't have any other symptoms of endocarditis, then it's probably not that. Next thing, really problematic, guys, syphilis, right? Caused by Treponema pallidum, which is a really small microscopic spirochete. AIDS can accelerate the course of the disease progression. Usually, this will be one of those STDs that you'll get a question about with a patient who has HIV. Primary infection, 10 to 90 days after infection, presents with a painless ulcer, which is called a chancre, and some local lymphadenopathy. This then progresses 4 to 8 weeks after the chancre presents, leading to fever, headache, malaise, and generalized lymphadenopathy with symmetric, non-pruritic maculopapular rash on the soles and palms, as you're seeing in that picture right here. Highly infective secondary eruptions include mucus patches called condyloma lata and alopecia. Meningitis, hepatitis, nephropathy, and many other things throughout the organ systems of the entire body. Systemic involvement can occur. Early latency, whereas a period from resolution of primary and secondary syphilis to the end of the first year infection, you're just going to see no symptoms, but there will be positive serology. So after all of this drama, it can become a little latent. It can then have a late latency period where it starts to become, somewhat negative serology and, not really showing any symptoms anymore. 1/3 of cases could progress as tertiary syphilis, whereas the 2/3 of cases are just going to disappear entirely and no more syphilis. So if you're an AIDS patient or if you have a really bad immune system, for whatever reason, then it'll progress to tertiary syphilis, where you're going to have 1 to 20 years later, destructive granulomatous gummas, which really look like this, very, very bad, neurosyphilis with tabes dorsalis, meningitis, Argyll-Robertson pupils, which constrict with accommodation but not reactive to light. So these are also called prostitute pupils. Cardiovascular findings include dilated aortic root, aortitis, aortic root aneurysms, and even aortic regurgitation. Right? Basically, it affects the aorta, and the reason it affects the aorta is because syphilis actually likes to live in the aorta. Right? So it goes into the part of the aorta that still has a lot of things happening. Above the renal arteries, you have your vasa vasorum, which is a part of the aorta that brings venous blood backwards, right? So that's where they like to live. They like to live in the vasa vasorum aspect, and they cause obliterative aortitis. They literally destroy the vasa vasorum aspect, they destroy the aortic wall, and all of that, of course, leads to all of these different aortic issues. It can lead to any one of these or multiples of these aortic issues. Really problematic. So diagnosis, you can use the VDRL test, but there's a lot of false positive test results because you can get false positive test results for any of these other guys. Even drugs, rheumatoid, many things. Many things can give you a false positive test result. But you can still do it. And if you get a result that's negative, you feel like it's definitely negative. It's a good idea in that aspect. Neurosyphilis should be suspected and ruled out in patients with AIDS, neurologic symptoms, and a positive RPR test. Right, so now here they're not really going much in depth, but they tell you to look at the table. So 2.8. Okay, all right. This is what they want you to see. So let's take a look at it. Diagnostic test for syphilis. Dark field microscopy identifies motile spirochetes, and if you could do this, which you obviously can't do the same day, then you're going to see the syphilis spirochetes and you're done. Then there's VDRL or RPR, rapid plasma reagent. These are both non-treponema tests. They're not specific to treponema, so they're rapid and cheap, but sensitivity is only 75 to 85%. Many false positive results used for screening and quantitative measurements. The treponema specific tests that are both sensitive and specific are these guys, and these are what you use as confirmatory tests if you get a positive test result. Right, now, if we go back to here, I have it a little better here. So let me see. No, wrong way. Syphilis. So right here. Okay. So I mean, in the sketchy microimage, they showed you a bunch of things. One of the planets is showing you what condyloma looks like. So these guys have the where do they write it? Condyloma lata, right? And the way you're supposed to remember that is, this isn't the fact, but the way you get condyloma lata is by having sex with a lot of women, right? Something like that. So when you use the LADA there, you remember it because you don't want to confuse yourself between condyloma lata and condyloma acuminatum, right? That's a different one that occurs in a different case scenario that you look at when you get there. But condyloma lata is the thing you pick over here. Visually, you can differentiate them. You can find on Google, if you look for condyloma lata versus condyloma acuminatum, you can clearly see the difference between them. The lata thing is smooth and wart-like. It looks like a wart. The condyloma acuminatum is actually not smooth at all. It's got a lot of almost like, what's that? What they always keep referring it to, like mushrooms. You know, they have the little bumpiness all over the place. This thing is very smooth, right? So they don't really have a very good picture of it because this is the only one they showed here. But that's kind of what you're seeing. It's a very vegetative lesion when you look at it. But generally speaking, in a good picture, you'll see that it's pretty smooth, right? Whereas with the condyloma acuminatum, there's nothing smooth about it whatsoever. Right? So you definitely should go ahead and look up some pictures of comparison between the two. Okay, let's just close a couple things because apparently the signal is not so good, but that's just something you'll figure out by itself. The other thing I wanted to show you guys was the understanding of how to figure out what test you're going to use, because they're not really doing that good of a job talking about it back there. So the names of things are written over here so you can really see what they're called, right? Because they listed out the acronym names for all of these right here. So the MHA is microhemagglutination assay, FTA is fluorescent treponema antibody. These are both treponema specific, right? That can actually see the treponemes in there. You can see the actual bug. Now, the non-treponema VDRL and RPR evaluate for presence of antibody against something called cardiolipin, and these tests are affected by anti-treponema therapy. So these tests are used for following disease progression. Right? So very key note to keep in mind. Where would you order VDRL and RPR again? You would order them again to see progression of the disease, if the disease is going away or not. Because when you use anti-treponema therapy, which by the way there's only one therapy, penicillin. Even if you have a penicillin allergy, you give them penicillin. You desensitize them a little bit and then you give them penicillin. There's no other way to treat it. So when you're giving them the treatment of penicillin, when you order a VDRL or RPR again in a week, it should show you that it got better. Right? So that's how you monitor disease progression. So this would be the perfect thing for monitoring disease progression. It's also what you would order the very, very, very first time before you have to go and order the confirmatory test, FTA and MHA, or any of the other ones they listed over there. These things detect antibodies that are specific to treponema antigens. So they're not affected by anti-treponema therapy, and they remain positive for life. Because once you've made the antibody, you're going to carry the antibody in you forever, because you now have immunity. So that being said, other than that, there's a lot it can also cause in newborns, right? So there's a congenital syphilis as well, which presents with some of these later two images they're showing right here. Facial abnormalities such as ragads, which are linear scars at the angles of the mouth, right? So this linear scar is what they're talking about right here, right? Snuffles with a nasal discharge, so that's the other thing here. Saddle nose, Hutchinson teeth like this, right? So you can see the middle notching they're pointing out right there. And saber shins and cranial nerve 8 deafness, right? So this is really problematic. You know, if you don't treat the mother, then it's going to occur. To prevent this, treat the mother early in pregnancy, because placental transmission typically occurs after the first trimester. So you don't even have much time. You don't have much time. Like if the mom didn't come in early enough, it's already passed on to the baby. Right? So it's a big issue right there. This was a table they had now in First Aid 2020, where they put all this in here. Not the craziest thing, it's just putting the same stuff we looked at into a table. And then this here is explaining the VDRL positives that you can get, the false positives, right? So a lot of false positive things. So they actually wrote it as PVDRL, pregnancy, viral, drugs, rheumatic fever, and lupus or leprosy. All of these are cases where you could have more cardiolipin. So if you have a lot of cardiolipin, VDRL will identify the cardiolipin, and then that's it. Yeah. So this is just used for screening purposes, right? It's sensitive, and it's going to help you rule it out, because if it's negative, then you don't have syphilis. but it's not going to do the spin. It's not specific, so you can't use it to rule it in. So you have to order a more specific test to rule things in, which is the FTA or MHA or whatever. And then after all of this, they don't mention on step 1 that you're supposed to use penicillin for treatment, but that's all you could treat it with. Once you start the treatment, you could really get Jers-Harsheimer reactions with this case scenario very commonly. It can occur with many other things too, but here is extremely common. So flu-like syndrome of fever, chills, headache, and myalgia after penicillin is started due to the killed spirochetes that release toxins. Right? So even as they die, they end up trying to harm you the most they can. Very key things to keep in mind. Now here, in CK, they teach you that you can also use doxy, right? Although that alternative format I've never seen as an answer choice, so I can't really attest to that. I mean, of course, if it's written here, it must be true, but as far as I've seen, as far as I've ever seen, if you have syphilis, if anyone has syphilis, if you have a patient with syphilis, you have to give them penicillin. And if they're allergic to penicillin, you desensitize them and you give them penicillin. I've never ever seen using doxycycline or even ceftriaxone, as they write for tertiary syphilis, to treat syphilis. So this table was really, brand new stuff for me. Even after I put it here, I didn't really care about it, and then when I gave my CK, I actually didn't have a question on syphilis. But that doesn't mean you won't, and that's kind of how the test is. There's so much to ask about that many of us will go through having a lot of topics that we didn't get a single question on. But if you do get it, then I guess follow the table. But it's still strange to me, and I have yet to see a question where one of these other answer choices are being used. More than likely it won't happen, because if you have a patient who's pregnant, you can't give the doxy anyway. And for tertiary syphilis, using ceftriaxone, again, I guess I could see it. It's a very strong antibiotic, but I've never seen it as an answer choice anywhere, right? So they tell you in the book, treatment, primary and secondary, you use penicillin IM for 1 dose. Then tetracycline or doxycycline for 14 days may be used for patients with penicillin allergy, but I've never heard of this. Pregnant patients who are penicillin allergic and have positive antibody titers must be desensitized and treated with penicillin. You see, so that I've seen, and of course for pregnant patients that's totally true, but tetracycline for non-pregnant patients, like male patients, I suppose, is not something I've really seen in questions before. So now we know, right? So that's kind of what we're really getting at, but for me, I've never seen that as a thing. Latent infection, treat with penicillin as well. Give 1 dose for early latency. Give a weekly dose for 3 weeks for late latency. And then it should hopefully go away. And in the side here, they're telling you about the Jers-Harsheimer reaction, where the treatment can lead to a flu-like illness. Nothing to worry about. Neurosyphilis is treated with penicillin IV for 10 to 14 days. And here for sure, they keep it the way I was saying it. If you have neurosyphilis, then penicillin allergic patients, regardless of pregnancy or whatever, should be desensitized before therapy and still be given penicillin IV. Right? So there's a little bit of a complexity with treatment. Generally speaking, you can just give penicillin for everything. But the tertiary stuff, and generally for neurosyphilis with the typhus dorsalis, you have to give penicillin IV. Right? And then for all the other things they're talking about here, you have other options. Especially for pregnant women, you have to give penicillin. But the men, I guess, and the non-pregnant women can use doxy and ceftriaxone if they're allergic to penicillin. All right. Then we have here genital lesions. So this is just related to the table over here, so we can take a look at it. First thing here we haven't looked at it yet, Klebsiella granulomatosis. Let me see if that's actually coming up. No, they're not going to talk about it separately. It rarely is spoken about separately. They don't really talk about that one much. Right, Klebsiella granulomatosis, which is granuloma inguinale, causes a papule which becomes a beefy red ulcer with the characteristic rolled edge of granulation tissue. Image A. What are these? I hate when the images are on separate pages. So this is actually a really good image of that, actually. Right, so this is a penis with granuloma inguinale right here. Right, so you can see what they're talking about with the rolled up edges and stuff like that. It's all granulation tissue. Raised red lesions with a white border, 1 or multiple, 5 to 10 millimeters, pretty small. No pain. Of course, the only ones with pain are these two in the middle. And then concurrent signs and symptoms are going to be the granulomatous ulcers. What else do they have? Even the table is spread up. Look at that. Clinical exam, you're going to see Donovan bodies. This is actually pretty highly tested. Although Klebsiella and granulomatosis is a very loyal topic, when they do ask a question about it, they want you to know about the Donovan bodies. So you're going to see Donovan bodies when you do a biopsy. That's how you figure it out. And treatment is with doxy or azithromycin. Either one works fine. Treatment for almost all of these guys are, very easy to remember. And it's stuff you've seen so many times, you'll have it down pretty well. But that's what you're going to get tested on the most when it comes to CK. For step 1, it was all the earlier things, right? So the way this table is divided is actually pretty indicative of what you're going to care about too, because for CK, you need to know these things. For step 1, you need to know what's on the other half of the tables earlier above. So that's your Klebsiella granulomatosis. Looks like this. Really weird, really ugly, and really bad thing to have on your genitals. Haemophilus ducreyi causes something called a chancroid, which is very painful. Papule or pustule chancroid, irregular, deep, well demarcated, necrotic, 1 to 3, 10 to 20 millimeters, very big, very painful, and it'll have inguinal lymphadenopathy, which is also going to be painful. And then they show you what it looks like. So even looking at it, you could tell it looks pretty painful, right? Difficult to culture, diagnosis is made on clinical grounds, culture on specialized media, single dose of azithromycin or ceftriaxone will take care of it. Right, so it's just, you could take care of it, sure, but the damage is done and it's very painful. And even after this heals, it'll leave marks, right? So it's going to be pretty problematic to deal with, aesthetically speaking. So papular or pustular, really bad chancroids. It's all ripped up, basically. HSV1 or HSV2, usually it'll be HSV2, right? So you remember that with it takes 2 people to have sex. So HSV2 is the one that you'll pick as an answer choice. I've seen questions where both are answer choices, but for the STD segment, it's mostly HSV2. HSV1 is the #1 cause of sporadic encephalitis, where you're just having brain issues, even the eye issues, stuff like that. But HSV2 is the one that's going to be the one related to herpetic Whitlow and just STDs in general. So you see regular red shallow ulcers, multiple of them. They're pretty tiny, but there's a bunch of them, and it's very painful. You also get myalgias and vulvar burning, even itchiness. And the way you diagnose is you take a Zank smear, which is a thing for herpes, and you should remember that from back in microbiology step 1, where it was described in Sketchy as a tank. So a Zank smear, you'll see exactly what herpes viridae have. You'll see multinucleated giant cells, and you might even see intranuclear or intracytoplasmic inclusions. Right, so those inclusions are a big thing for all the herpes viridae. DFA or serology is another thing you could use, but viral culture is the most accurate test. And treatment is thankfully very easy. You just start them on acyclovir, famciclovir, or even valacyclovir, and it should help. Remember, for CMV, you use ganciclovir. And for both of these case scenarios, if they're resistant to this cyclovir medication, then you could use foscarnet. Right, so that's only used for resistant patients. Not really a high-yield medication to use, not that commonly ordered, and it's actually pretty expensive. So you really only order this medication if they're resistant to the previous answer choice. Right, now HPV, as you can see here, looks very similar to that thing we were looking at for syphilis. Right, the condyloma lata. So this is a very similar looking lesion. So you want to make sure you can differentiate them very easily. You don't want to get confused. That's your condyloma acuminata. Right. So if I could, let me see. Actually, I actually can. I can move this image. So I'll show you something right now. So let's put these images right next to each other. And these are both bad images, and I love comparing bad images because that's what you're going to get on the test, right? So these are actually bad images to help you differentiate between the two. The left side, letter E, this is your condyloma lata, which you get from syphilis, and that's because of sex with a lot of people. Condyloma acuminatum is the HPV thing, which is rarer to get because usually you would assume that hopefully the person has been vaccinated against HPV. And HPV vaccination is a very strange vaccine because you can't get it after a certain age, I believe age 26. So that's like you have to get it when you were in college or something, in your early 20s. So now, upon first visualization here, there's not much of a difference. And they look very similar to each other. And as I said, these are both bad pictures that are now meant to be used for differentiating between the two. But this is what you're going to get on your test. So how do you differentiate? Well, the only real differentiation you're going to get, because these two pictures, I could switch them up with each other and teach you the same shit and you would have no idea. So the truth of the matter is the fact that this guy, the syphilis one, is supposed to have smoother bases. Smoother bases. If we're looking at it from a side angle, so the top is supposed to be smooth up here. Whereas this guy is never smooth. So this guy is going to have like all this crumpliness on each of the bases right here. On top of that, it's also always going to be more clumped up, and it can be in the anal area. That's usually another giveaway. If they show you this picture and it's actually the anus and not in the genital area, then you know it's HPV. In these two pictures, there's no way to differentiate them. Right? So that's the point of this shit. So what you want to do is look up more pictures where you can actually differentiate them, because there's really no differentiation between the two. And they're both named very similarly too, which is very easy to forget and confuse on the day of your test. When you're done with 200 questions and you're moving on to 200 number 1, right? Number 201, you're losing it already. So it's very intense and it's very easy thing to mess up, but also an easy question that you don't want to mess up because there's no thinking involved, right? It's just a visualization thing. So condyloma lata, syphilis, condyloma acuminatum, HPV, right? And it's just about the smoothness. That's all you can really use. How clustered up it is, how smooth the top is, and then on top of that, if it's in the anal area, right? So condyloma acuminata warts, very, very cauliflower-like. That's the vegetable I was trying to think of. Right, so the cauliflower likeness you can see in this picture pretty well, actually, right? It's all clumped together and it's coming up like a cauliflower. So that's kind of what they're talking about here. And when you have a patient that presents with this, literally all you can do for them is rip it off. Cryotherapy. Right, so you just freeze it off, or you could do laser excisional therapy. You could do topical agents like podoflotoxin, imiquimod, or even trichloroacetic acid, which are 3 answer choices you've probably never seen. You've probably never seen any of these answer choices for this thing, because generally speaking, all we really do is just cryotherapy. You know, it's the easiest thing to do. You can find it in most clinics that are supposed to deal with this, and that's it. Laser or excision therapy is dangerous because you have to be very proficient at that as a doctor, and the topical agents are not quick enough. Most people who have an HPV lesion, a wart, and they come in for it, they want to get rid of it right away, not take some kind of topical agent to hope it goes away slowly. And then we just finished talking about treponema, right? So that's it for that. E and F are showing you exactly that, right? So in E, I think that's the ulceration you get for syphilis. Yeah, the papules. That's your little chancre. And then F was... what is F showing you? I'm not quite sure. Did I miss it? E... yeah, they didn't even label what F is showing you, because I can't really tell what they're trying to get you to see here. This actually looks more like something you would see for... is it the herpes guy? Oh yeah, it is the herpes thing. Okay, the multinucleated giant cells for F. Yeah. So you see, like, I actually didn't know, but just because of experience purposes and seeing stuff like this, like, there was... the general thing would be to think this must be something related to syphilis too, but there's really nothing like this in syphilis at all. I mean, I would be looking for spirochetes, right? And there's nothing like that. This is actually a microscopic image of something with H&E stain, and I'm just seeing multiple nuclei in here. So before I even knew, I knew to check for herpes, because that's the only place you would see something like that. For some reason, they put it as image F rather than, you know, in going in the correct chronological order. So it's really important to have that experience of being able to look up images and just identify what it is without much hints, because that's kind of what NBME was always doing to all of us, right? So it's like, it's a scar. Once you have that experience on NBME of shitty questions, you're forever scarred. So let's look at some of these questions we skipped here. There was one for syphilis all the way up here. Alright, so this one says, a 42-year-old man comes to the office due to a week of subjective fever, sore throat, malaise, headache, and skin rash. The rash, okay, so everything was okay until he had a rash. The rash began on his trunk a week ago and has now spread to his entire body. He has no chest pain, shortness of breath, diarrhea, or urethral discharge. He was diagnosed with hypertension 2 months ago and started lisinopril. he has had 3 new female sexual partners over the last year, which falls in line with the condyloma lata aspect of having sex with a lot of people, right? So 3 new female partners. He drinks alcohol occasionally. He doesn't smoke or do drugs. He doesn't do any unusual outdoor activities. So the unusual outdoor activities are supposed to help you rule out things like the rickettsia, which also causes a rash that starts in the chest and then spreads out to the rest of your body, just sparing the palms and soles. Right, sparing the palms and soles. Compare that to syphilis, which is part of your CARS mnemonic, C-A-R-S. The S in syphilis actually involves the palms and soles. So, very important thing to keep in mind. If you haven't revisited that in a while, we can go back and look at it really quickly right now. So that's right here. Right, so palms and soles rash is seen in Coxsackie A, Rocky Mountain spotted fever, which is rickettsia, syphilis. Right, so rickettsia also does it, or is rickettsia. Right, so rickettsia also has similar rash as they were describing in the question, starting at the wrists and ankles and then spreads to trunks, palms, and soles. Okay, right. So the reason they told you he doesn't do anything outdoors that's weird or unusual is because it could be rickettsia, but they ruled it out. That's a very important sentence to keep in mind. Rickettsia, they have these images for rickettsia and Sketchy Micro where you're basically going mountain climbing. Right? And in this last guy up here, you can see even his palms and soles have the rash all over the body. Right? So that's your Rocky Mountain spotted fever. So they made sure they let you know that he doesn't do any outdoor activities like mountain climbing, which rules out rickettsia as an answer choice. So the CARS mnemonic, Coxsackie A, rickettsia, and syphilis. They all cause palms and soles rashes. He has not done any unusual outdoor activities. Temperature is fine, blood pressure, pulse, all that's okay. Exam shows a full body maculopapular rash without excoriations. Several raised gray mucosal patches are seen in the mouth. Cervical, axillary, inguinal, and epitrochlear lymphadenopathy is present. HIV is negative. What is the most likely cause of his symptoms? So then the only thing you had that you could work off of, if we look at everything I've highlighted, is the 3 new female sexual partners. So that just leaves you with syphilis. That's it, right? I don't know what the other 25% of people were thinking that chose Epstein-Barr virus, because Epstein-Barr virus doesn't cause a rash. Right? There's no rash in Epstein-Barr virus, and even if there is a rash, it's definitely not all over the body, because then you would definitely remember that. That's a pretty big deal to forget. Right? So Epstein-Barr virus, 25% of people picking it really didn't make any sense. I mean, yeah, sure, you get a lot of lymphadenopathy in Epstein-Barr virus too, but with Epstein-Barr virus, you want to think of mono. You want to think of college students laughing at each other and making fun of that one person who has all this lymphadenopathy and telling them, oh my god, you have mono. It's like, it's a childish thing. Epstein-Barr virus is not something that really causes sexual stuff in adults. It's very rare, right? It's usually going to be a younger patient. This is an older patient with 3 new sexual partners and nothing else to work off of in this question. Syphilis. Secondary syphilis occurs weeks to months after exposure to Treponema pallidum and develop primary syphilis, which is a chancre. Secondary is often characterized by systemic symptoms, widespread lymphadenopathy, gray mucus patches, and condyloma lata genital papules. He has some of these things, although I don't think they did a physical exam of his genitals yet. Right? They didn't. Yeah, they haven't done a physical exam of his genitals for whatever reason. They only said he doesn't have urethral discharge. I don't know. They also get a maculopapular rash that involves the palms and soles. The presence of epitrochlear lymphadenopathy is particularly pathognomonic. Right? Epitrochlear lymphadenopathy. Very specific kind of thing for syphilis. Epstein-Barr virus does cause similar symptoms, but there's no rash. So that was all there is to this question. I'm not sure what they were thinking. Now, here is a question on Coxsackie virus. There's a 5-year-old boy brought to the clinic due to 3 days of fever. For the past 2 days, he has had throat pain and has not eaten well. His father is worried because the boy is due to start the fall school term in 2 weeks. He has no chronic medical conditions and is current with his immunizations. He lives with his older brothers, parents, and grandma. Temperature is very high. Blood pressure, pulse, respiratory rate. Oropharynx has several scattered 1 mm vesicles on the anterior palatine pillars. Several gray, shallow ulcers are also seen on the soft palate and uvula, but the tongue, lips, and buccal mucosa are spared. Skin has no rashes. Remainder of his physical exam is fine. What's the most likely pathogen associated? Well, anytime you ever think of anything vesicular, it should ring a bell for like the herpes viridae, right? Like HSV1, HSV2, and then CMV and stuff like that. But here, what we're talking about seems a lot like it's just going to be Coxsackie, not the things that these people fell for. So you see how, because of the vesicular stuff, 20% of people did end up choosing HSV as an answer choice. And 15% each chose either adenovirus or strep pyogenes. Now, strep pyogenes is the one that didn't make any sense at all. There's no reason for you to pick strep pyogenes here when, we don't see any of that strep pyogenes symptomology in this patient at all, for the most part. I don't see it. He has oropharyngeal issues with vesicular anterior palatine pillars having vesicles, right? That's really weird. The gray shallow ulcers on the soft palate are also very weird. You don't see those things in strep pyogenes, right? And it really had nothing to do with herpes either. I'm not sure what they were thinking when they thought this might be herpetic gingival stomatitis. Look, they have a breakdown table here. So herpetic gingival stomatitis, which occurs with HSV1, would occur in his age group, 6 months to 5 years. It would have fever, pharyngitis, erythematous gingiva, and clusters of vesicles on the anterior oral mucosa. You just give acyclovir and they'll be okay. But this guy doesn't just have that. He has more and other things. Herpangina and herpetic gingival stomatitis are common vesicular oral infections in kids. How do you differentiate them? They present similarly with fever and pharyngitis. However, the primary distinguishing feature is the location of the oral lesions. Herpangina is caused by Coxsackie virus and typically affects kids in the late summer or early fall. Patients have gray vesicles that progress to fibrin-coated ulcers. The oral enanthum is located in the oropharynx and oropharynx on the posterior soft palate, anterior palatine pillars, tonsils, uvula. Unlike hand, foot, and mouth disease, another condition caused by Coxsackie virus, herpangina is not associated with the rash. Right? HFM, hand, foot, mouth disease, very similar, and a rash. Also Coxsackie. Now, when you look at the sketchy micro image for Coxsackie, you would see this summer association. And the association with the season is actually a pretty critical thing. And they gave you that association in the question too, because they told you that the kid's about to start school in fall soon, which means they must be in summer. This is the Coxsackie image, right? So on the left is Coxsackie A, on the right is Coxsackie B, which is the one that causes the cardiac issues. And you can see from the way the little girl is dressed and the weather outside that it is a sunny summer day. She's dressed in what looks like a bathing suit because it's summer. The sun is to remind you that it's a positive DNA, right? Oh, sorry, positive RNA virus, right? RNA. So the sun in all of these was a positive RNA virus. The moon with the cloud looking like a minus sign was a negative RNA virus. So this is just giving you the entire Coxsackie breakdown, and knowing the summer aspect of things is very critical, causing this kind of flu-like and really bad cold kind of issue in the summer in a very viral manner with involvement of vesicles and oral mucosa. This is all very viral, not very bacterial at all. And bacteria and viruses work in different manners. So that's really all it was. Otherwise, the two guys look very similar. But it's the location and the timing that's a big deal, right? And then because of that, treatment is a big deal. On your own step 2 CK, your question wouldn't even ask you what's causing it. The question would just say, what should you do for treatment? What's the next step in management? They would assume that you were able to figure out that it's herpangina, and you would pick the answer choice of just give supportive care. No treatment necessary. The kid's going to be okay. Whereas if you assumed that it was herpetic gingival stomatitis, then you would pick the answer choice of acyclovir, and you'd be wrong. Alright, so this question, for teaching purposes, is the way it is, so you can learn the differentiation. On your own step 2, they won't need you to learn the differentiation, they want you to know the differentiation in treatment. Right, so you're going to have to pick a different treatment based off of what you caught. So very similar presentations of a lot of these infections. You need to get good at picking on the few things that you need to catch to get this stuff down correctly. They didn't just waste time telling you that he's going to start school in fall for no reason. That means it's summer. The placement of the vesicles in the anterior palatine pillars. as well as the fact that it was also involving shallow ulcers on the uvula, tongue, lips, and buccal mucosa. Those things being spared was all the key things you needed. Right? Several grade shallow ulcers are also seen on the soft palate and uvula. Right? So up to here you saw it. Soft palate and uvula had it, but the tongue, lips, and buccal mucosa was spared. So because you had the palate, right, you had the uvula, the thing hanging in the back of the throat, and you have vesicles in the anterior palatine pillars, which basically is just these two guys, you can see the difference. Right, this thing only causes vesicles on the anterior oral mucosa and lips, but the lips and buccal mucosa are spared. Right, so the difference really just comes down to whether or not the lips and oral mucosa are involved. Right, that's it. So palate and uvula, herpangina, lips and oral mucosa, herpetic gingival stomatitis, which is in the name. It's involving your gingiva stomatitis. Right, the gingiva are more so in the front. The uvula and the palate are more in the back. So that's how you use the differentiation to get this correct. Right, between the two guys. That's really all there is that we can see in this question. And then of course classic EA summer. Right, so that's another little thing you can use. That's generally it. Otherwise they're very similar to each other. So great question, a lot to learn for differentiating between the two, and then the treatments are different too, so the differentiation is critical. If they were treated the same way, the differentiation wouldn't be a big deal. If you gave oral acyclovir for both things, then we don't really care to differentiate that much. This one is related to something that's actually pretty rarely tested, but it's also very rarely understood by students. 34-year-old man is evaluated for malaise, palpitations, last 4 weeks, so he has palpitations. Reports low-grade fevers, denies any sick contacts or recent travel. He has DM1, strong family history of colon cancer. He himself has a holosystolic murmur at the apex. So colon cancer and palpitations are related, right? Because there is a bacteria that causes both things. A holosystolic murmur is heard at the apex. Echo confirms a 5 mm mobile mass attached to the anterior leaflet of the mitral valve. So he has a, what do you call this thing? A vegetation on his mitral valve that's causing mitral regurgitation. Okay. Blood cultures grow Eikenella corrodens, which they kind of made it easy for you by telling you what it grows. What is the most likely predisposing condition to his current condition? And the correct answer was just periodontal infection. So where did Eikenella come from? He has infective endocarditis of the mitral valve due to infection with E. corrodens, which belongs to the HASIC group. So if you've never seen the HASIC group, or if you forgot about it, or you just haven't revisited it enough times, it's worth looking at. Let's see if I can find it. Yeah, perfect. So they mention it right here on page 335 with the cardiovascular section, and I was pretty sure they mention it in micro too, but I probably just can't find it right now. Yeah. Alright, that's fine. We can look at it right here since this is the topic at hand. So bacterial endocarditis was obvious in our patient, right, because he has the mitral valve vegetation. And then this HASIC topic. So Haemophilus aggregatibacter, Cardiobacterium, Eikenella, which is our question, and Kingella. These are weird bacteria that are rarely ever tested that are related to getting bacterial endocarditis, right? And you remember the two ways of getting them, right? Either acute or subacute, and it was either because you have other issues with using IV drugs, or you're a patient who just had a dental procedure done, right? Usually if you ever go in for a big time dental procedure, you need to make sure you start taking antibiotics ahead of time, and your dentist will give it to you. So the HASIC group, they list out for you, right, and then they tell you these organisms are responsible for only a minority of cases of infective endocarditis. Eikenella is a gram-negative anaerobe and a part of normal human oral flora. It can cause infective endocarditis in the setting of poor dentition or periodontal infection, along with dental procedures that involve manipulation of the gingiva or oral mucosa. Alright, so that's generally all that question was for, just to remind you of the HACCP group and the fact that you can get weird infective endocarditis questions related to poor dentition, not exactly having gone for the dental surgery yet. Dental surgery usually will be a very dense question, so they'll keep it specific to that as far as STEP is concerned. A 24-year-old man comes to the office for evaluation of abnormal vaginal bleeding. 24-year-old woman comes for abnormal vaginal bleeding. She has a history of heavy irregular menstrual periods for which she had progestin-releasing IUD placed 2 years ago. So she got the IUD because it's mainly progestin-based, so it'll stop the bleeding. Estrogen is what causes the bleeding. After IUD insertion, she became amenorrheic. However, for the last month, she has had light vaginal spotting with wiping. She also recently developed intermittent pelvic pain that has now become constant and unrelieved with ibuprofen, so that's pretty bad, pelvic pain. She has no chronic medical conditions, no prior surgeries. She has had 3 sexual partners in the last year and does not smoke, drink, or use drugs. But they're not telling you if she uses protection, and she most likely doesn't since she got an IUD. You know, she's a young woman. At that age, an IUD makes you feel like you're perfectly safe from everything in the world now. So most likely does not use protection, something that you have to assume. For 2 reasons. 1, because of her age, and 2, because she has an IUD, which usually is an excuse for not using protection, right? But the confusing aspect is that the IUD at very best will prevent pregnancy, but it won't prevent infection, right? So then that's something you need to understand in the question. Another reason you can assume she doesn't use protection is because they're not mentioning it. They didn't say she has protected sex, right? Family history is fine. Urine pregnancy test is negative, so of course she's not pregnant because that's what the IUD is helping with. What is the most likely cause of her symptoms? But intermittent pelvic pain is pelvic inflammatory disease, PID, right? I don't know why the others chose what they chose. 15% chose endometriosis, and a young woman randomly getting endometriosis. Very unlikely. And then progestin-induced endometrial atrophy. At this age, I wouldn't think so either. So I'm not sure where this answer choice came from, and we can look at the explanation now. After insertion of a progestin IUD, patients may experience 3 to 6 months of irregular bleeding due to gradual endometrial thinning, progestin-induced atrophy, often followed by amenorrhea. Patients with stable amenorrhea who develop new onset abnormal vaginal bleeding, such as her, require further evaluation. In this patient with a change in bleeding pattern and new onset pelvic pain, the most likely diagnosis is pelvic inflammatory disease, a polymicrobial infection of the upper genital tract involving chlamydia and gonorrhea. Risk factors include a young age, multiple sexual partners, and inconsistent barrier protection use, which she fits. PID is typically a complication of Neisseria gonorrhea and chlamydia cervicitis. PID is diagnosed clinically, and patients are prescribed empiric broad-spectrum antibiotic therapy to prevent complications before even results come in. IUD removal is not required. Removal increases the risk of unintended pregnancy and does not affect the treatment outcome, so don't do it. Endometriosis is a common cause of pelvic pain, but it is an extrauterine disease that does not have abnormal vaginal bleeding. Right? Endometriosis is usually the thing with the chocolate blood and whatnot, but again, it doesn't cause abnormal vaginal bleeding. This question is comparing the AUBs, abnormal uterine bleedings, and mixing it with infections. So you need to know your vaginal issues very well too, of course, right? You can get tested on that as well, and we haven't gotten into that, but it's discussed very well in step 1 as well. And you have the book if you want to go check it. Now, this progestin-induced endometrial atrophy, this was the people that picked this answer choice were the group of people that were proud of themselves for remembering that it can do this, right? Because you need both progestin and estrogen, yes, and if you're just on progestin, then of course you're going to have endometrial thinning, and then you're going to get progestin-induced atrophy. That's stuff that will happen, but that's not her problem. That's not the reason she has intermittent pelvic pain, right? So then the more key thing to focus in on was her young age, 3 sexual partners, and the fact that she has an IUD, which means she probably doesn't use protection, and now she's got infection. Right? So very good question. And then what happened here? Let's make this nice and green real quick. Okay. So what's happening in this question? 21-year-old man. I think this is related to. Oh, okay. Yeah, this is the one about treatment. So let's see what's happening. There's another question about treatment that's even better than this. I just don't remember where it is, and you have the table and everything. It's not. Let me just make sure. It's not right here, is it? No. No, it's not here. Okay. So whenever I'll find it, I'll make sure I show it to you guys, and I'll move it to here too. So a 21-year-old man comes to the office, got the pencil. So a very young guy, right? Very young guy. Due to a 3-day history of dysuria and penile discharge, okay? No fever or scrotal pain, 2 recent female sexual partners, doesn't use condoms, no chronic medical conditions, temperature's fine, everything, vitals are okay. Edema in the urethral meatus, mucopurulent penile discharge, no ulcer or rash, scrotum's fine, no inguinal lymphadenopathy, rectal exam is fine. I don't know why they did a rectal exam. Urinalysis reveals 5 to 10 white blood cells. And then they ordered the NAAT. Okay, so that's what you're supposed to do. And it's positive for Neisseria gonorrhea and negative for C. trachomatis. Testing for syphilis and HIV are negative. What is the best pharmacotherapy for him? So a lot of people fell for this, right? Because the nucleic acid amplification testing on his urine told you that he definitely has gonorrhea, and it came negative for C. trachomatis, but that does not mean he definitely does not have chlamydia. It just means he may not have chlamydia, or he may. So since they got the test results in this manner, a lot of people, 35% of people chose ceftriaxone only. They chose treat for gonorrhea only. And you never do that. You never do that, right? Treat for both ceftriaxone and the one azithromycin tablet that will kill the chlamydia. And then they tell you, he has acute gonococcal urethritis with negative chlamydia, HIV, and syphilis. GU is, or gonococcal urethritis is transmitted through sexual contact. Although asymptomatic carriage and transmission is common in women, men with GU are usually symptomatic. The urethral discharge in GU is typically purulent in contrast to the more watery discharge in non-gonococcal chlamydial urethritis. Diagnosis is confirmed with urethral culture and NAAT of the urethral swab. The recommended treatment includes ceftriaxone and azithromycin, which can be administered in a single-dose regimen. In case of medication tolerance, a 7-day course of doxycycline can be substituted for the azithromycin. Although ceftriaxone alone is often effective, dual agent therapy is recommended due to increasing antibiotic resistance. Combination therapy is also more effective than ceftriaxone alone for concurrent pharyngeal infection. Plus, the addition of azithromycin provides coverage for chlamydia co-infection, which is often present. In addition, empiric treatment of sexual contacts of patients with GU or non-gonococcal urethritis is recommended. If gonococcal infection is confidently ruled out, then azithromycin or doxycycline alone may be used to treat chlamydia trachomatis infection. But you can't do it the other way around. Since Neisseria gonorrhea has high resistance, we just saw earlier that it's said to use multiple forms of treatment, even though the only real thing was ceftriaxone. So we add azithromycin anyway, because it's another antibiotic and it'll help. So whenever you're treating gonorrhea, you treat for both gonorrhea and chlamydia. If you're only treating chlamydia and you've successfully confidently ruled out that there's no gonorrhea, then you don't need to give anything for gonorrhea. Right? That's kind of what they're saying. In the real world practice, you treat for both things either way, no matter what, because you never know how accurate a test might be, and you don't want to risk PID, especially in a woman, because then ectopic pregnancies occur. But book-wise, as simple as this topic should be, gonorrhea versus chlamydia, they complicate it. They've complicated as much as they can. Rule of thumb is, if your patient has gonorrhea, you give them both things, ceftriaxone and azithromycin, even if their chlamydia test result is negative, because the azithro will also help with the Neisseria, which has high resistance. If your patient only has chlamydia, you treat it with 1 tablet of azithromycin. You successfully and confidently ruled out gonorrhea, you don't add ceftriaxone. Azithromycin kills chlamydia and they're okay now. And so that's kind of how you want to work with that, and just keep that in mind. Right, and this table here for urethritis in men is showing you azithromycin or doxy plus ceftriaxone if gonococcus is not ruled out. Right, so azithromycin or doxy is all you need for the chlamydia aspect. Right, and then if you don't know whether gonorrhea is there, then you also add ceftriaxone. If you know gonorrhea is ruled out, you don't add ceftriaxone. So this is how they make this topic a little more complicated than it needs to be. Alright, so that's it for that, and then in the next video we'll move on to genital urinary infections.